Welcome to our live webcast, Outpatient and Rapid Recovery Total Joint Arthroplasty. Thank you for joining us. My name is Eric and I will be the operator for the presentation today. Before we get started, I would like to take a moment to acquaint you with a few features of this web event technology. At any time, you may adjust your audio using any computer volume settings that you may have. Closed caption is available. On the right-hand side of your screen, you will see the text chat window. There is a large window which holds all of your sent messages, and a smaller text box at the bottom where you will type in your questions. To send a question, click in the text box and type your text. When finished, click the send button. All questions that you submit are only seen by today's presenters. Your questions will be responded to in the order in which they were received and will be addressed at the end of the presentation. You will also be able to ask questions via telephone at the end of the presentation. At the conclusion of today's program, we ask that you complete a brief CME evaluation summary form. Please take a moment to complete this survey in order to receive credit for attending the webinar and providing feedback of the webinar. We are joined today by our speaker, Dr. John Dundon. At this time, I would like to turn the microphone over to our speaker, Dr. John Dundon.
So hi, I'm John Dundon, fellowship-trained joint surgeon here at Morristown. Originally from Ohio, trained in Ohio, and then my fellowship in New York City at NYU. Here today to talk to you guys about outpatient and rapid recovery total joint arthroplasty. So this encompasses a couple different things. The idea between outpatient and rapid recovery encompasses not only the true outpatient total joints, which are the people who are going home the same day, but also the rapid recovery patients who are going home within 24 hours of surgery. This is where joint replacement's heading, whether we like it or not, and there's ways in order to do this safely and facilitate this. And that's what we're going to go over today. How do we facilitate this? How do we make it safe? How do we make a good patient experience? And how do we make sure we improve outcomes in the process? So if you have any questions, type them in. If we have time, I'll try to go through them right as we're going, if they're quick, and if not, we'll address anything at the end of the presentation as well. But if you need something, please feel free to stop me. So I don't have any pertinent conflicts of interest here in this talk. So the number one thing that we have to do with orthopedics and with outpatient total joints is to try to manage perceptions and expectations. That's one of the biggest things that we see. Everybody talks to someone who's had a total joint. All the primary care docs have lots of patients who've had total joints, and everybody has a different experience and a different perception of what's happening. In order to successfully accomplish this, we have to manage what the expectations are and provide realistic goals for what we're going to do. And everybody's got a different way that they view this. Now, as orthopedic surgeons, obviously, we see the bright side of it. You know, we see fancy, shiny new joints, joint replacements. We have a very positive outlook on this. You know, we see happy patients getting back to life, doing things that they want to do, where other people may have a different perception, and we have to manage that as well if we want to be successful. You know, a lot of the primary care docs I talk to, they see patients who are in pain. They see joint replacements with hammers. They see people who may struggle to be able to get through this, and they wonder how we're going to do this as an outpatient. And if we don't have the primary care team on board, the patients won't be on board as well. And then, most importantly, for the family and the patients, they see this. They go on YouTube. They see the videos with big mallets and big hammers and blood and chunks of bone. And we'd have to find a way in order to manage not only the expectations, but what's going to happen and how we're going to be able to get people through this. That's probably the most important job that we have with doing this. So, the big question is, why even do this? Why do total joint arthroplasty as an outpatient? Why do rapid recovery? That's the first question we have to do, and that's the first barrier that we have to do. But we find that as we do this, we lower all overall healthcare costs to the system. We help to offload patient volume. We can decrease the risk of complications and infections by doing this, and we can also improve patient satisfaction through this. So the how and the why are what we need to talk to next, and then we're going to talk about how we're going to accomplish these things. So this is from Becker's. This is an article that came out recently, and these are kind of 5 trends in total joint surgery that everybody's starting to see. And this is why we're starting to get into these things, because it's happening before us, and we have to be prepared and we have to be on the forefront of these things. So minimally invasive surgery and pain management techniques, these are key. And these are parts that we can do on the operative side that we'll talk about later in order to get patients discharged early. This is one of the prime focuses for rapid recovery. If we can't manage pain, if we can't get people mobile, if we can't get things going, we're never going to be able to accomplish what we want. 20% of total knee replacements and 15% of total hip replacements are expected to be performed by outpatient. This is in the Medicare population by 2025. It's higher in the general population. So these are big numbers, especially when you're talking about the numbers of total joints that we're going to be doing a year. The growth of this, it has to do with multiple things, but again, it's mostly patient and physician related. It's all about social readiness, appropriate patient selection, and financial considerations. Significantly cheaper to do things as an outpatient than it is as an inpatient. And we're starting to see this as total knee in Medicare has already come off the inpatient only list, and total hip is coming off soon. So Medicare is already pushing this as we go forward. Outpatient total joint procedures, they can cost 20 to 30% less and even higher when you look at some instances than when they're performed in an inpatient setting. And this leads to short and long-term savings for the patients. Lower complication rates, lower costs, people are happier with those things. So this is kind of the projected trend for where we're seeing overall total joint replacement going. This is a graph showing what we're anticipating in the U.S. market. And you can see by 2026, we're expecting almost half of our total joints to be done in an outpatient setting. That's a significant number, and so we have to prepare not only ourselves for it as surgeons, patients for this as well, and the primary care physicians too, because once the patients are out of the hospital, people don't just call the total joint doc whenever there's something going on after their hip replacement or knee replacement. One of the first people that they call whenever they have a fever or anything else going on is the primary care physician. So they're integral in this and have to be not only educated, but an integral part of making sure that these patients are safe, healthy, and moving forward and progressing in a good fashion with these outpatient total joints. So here's the actual numbers. When you look at these, it's about 40 to 50% less when you do these in an ASC compared to in a hospital inpatient. This is just counting the facility fees. So you're talking half the cost when you're doing them inpatient versus outpatient. So that's why insurance companies are pushing this. CMS has also created tools, they call it the procedure price lookup, where you can actually, the patients can go on the database and look at the costs in different settings and see what their copays are, where it's going to cost more, where it's going to cost less, and they can actually review these things prior to the procedure. And there's the actual numbers behind the graph that I just showed you for the outpatient. By 2026, we're expecting almost 51% outpatient. So that's a significant number, and we have to be ready for it. Now, will we honestly hit those numbers or those projections? I doubt that we're going to hit those numbers, but I think we'll be close. The other reason outside of cost alone is offload hospital volume. Hospitals aren't growing at the rate that some of these procedures are, and now we're coming into bed crunches, PACU holds, other things that are starting to limit what we can do in the hospital setting because of the volume and the exponential increase in patients needing total hip and total knee replacement. One of the biggest reasons people are needing total hip and total knee replacements is not because arthritis is getting worse, it's because the procedure is becoming more successful. When you're able to do these things with less pain, lower complication rates, and improved quality overall and improved function at the end of the procedure, more people become candidates for this. So you can see, by 2030, we're expecting this to grow to astronomical numbers. By 2060, they're expecting 1.23 million total hips, 2.6 million total knees, and there's no way that the hospital system will be able to respond to all of this without this. We got a question here from Bridget. It says, are the joints considered outpatient if done in the hospital and they go home the same day? Depends. So there's hospital outpatient surgeries that can be considered that way, and those can be qualified as outpatient. Some of the studies will do that, where they plan people as an outpatient. They are not considered an inpatient. They don't qualify them for surgery as an inpatient. They qualify them as an outpatient, and they will go home the same day. So some of those patients, yes, will qualify as outpatient as well. And there's different complication rates with people from ASCs to people done in a hospital setting who go home outpatient compared to those people who stay. And those are things that we have to think about as well. So that's a good question. Yes, those are considered outpatient, but they kind of fall into a different group. But they're still part of that outpatient rapid recovery protocol. So the other reason as to why to do this is decreased risk of infections, complications, and other things. So the old pathway was people are in the hospital for 3 days, They went to a nursing home, and after 2 weeks in the nursing home, they came out. Well, we started to see in the literature over the past 4 or 5 years that there was significantly higher rates of complications associated with that kind of pathway, where we kept people in the hospital for several days, sent them to a rehab facility, and then sent them home 2 or 3 weeks later. Not only was the complication rate double, the readmission rates were double, and the infection rates were 7 times that of the people who didn't go to these rehab facilities. So this is a big swing. This is a big swing that we're seeing. And now, that doesn't mean that nobody should go to rehab facilities. There are people who need to go to these rehab facilities, but it's the people that don't have to go to these places that we are trying to handpick and move them out so we can lower their risk, and that's what we're finding. This is a database study. This is so it's a lot more skewed, but it's showing even higher numbers. This one was out of HSS, where they just did a database study on people who went home versus people who went to an inpatient rehab or skilled nursing facility. Now, this wasn't able to be correlated because it was a database study, but in this specific study, this is one of the worst ones I saw. It had 4 times the higher rate of infection, 50 times the rate of UTI, 44 times the readmit rate, 31 times more likely to have wound problems, and 93 more times likely to have respiratory complications. Now, given these people are going to be on the sicker end, so it's a little bit skewed, but it just goes to show that there's significant morbidity associated with doing these things, which is another reason why we're pushing towards this rapid recovery. Get people home, get people back home the fastest way that we can and safely. And we are even seeing this with patients who live alone. So living alone doesn't mean you need to go to a rehab facility. A lot of people start to see it as that, but we have lots of resources at this time in order to minimize the risk of people going home alone. Now, home alone doesn't mean nobody to help you out at all. You always have to have a neighbor or a friend, or we call them a coach, in order to help them through the process. But we've seen that patients who live alone, and this study highlights that, they're a little bit more common to stay overnight in the hospital rather than going truly outpatient. They're going to utilize more home health services, and we're okay with that. If we need to send a therapist to the house for a few weeks, whatever we need to do to get them home safely, we'll do it. But the big thing with this study, there's no difference in complications, and there's no difference in unplanned medical visits or emergency room visits or readmissions associated with these patients. So you can safely discharge people home, even if they live alone. We just have to set up and make sure that they're safe when they do it. So outcomes, why else would we do this other than for outcomes? And this is, again, going with complication rates that we're seeing. This is outpatient versus ambulatory surgery center, total joint replacement. And what we see for total knee and for total hip both, we see significant differences in both 90-day and 30-day readmissions for patients being performed outpatient. Post-surgical complications are significantly less as well. And so this goes to Bridget's question before. This is even within patients who go completely outpatient as standalones, whichever one it is, versus going to the hospital and still going home the same day. Even those patients, you'll see a significant decrease in complications. Now, to the true inpatients, there's, again, significant and even stronger p-value difference in 30-day, 90-day readmissions and post-surgical complications between inpatient and true outpatient total joints. So we're decreasing the complication rates, we're decreasing the readmission rates, and we're able to safely perform these things. The other thing that we're seeing is improved patient satisfaction with these, especially right now with COVID-19. We have a lot of patients who are scared to go to the hospital, and if they're candidates, it's an excellent way to get people over their fear of the hospital and still be able to get their procedure performed. People are always scared of community-acquired infections, coughs, and some people just want to recover at home. These are all things we can do to improve patient satisfaction as well by moving them into an outpatient setting. So this is a study that they performed on outpatients, and what they did was they randomized and they took patients who went outpatient, patients who went inpatient, and they just did satisfaction surveys on how they felt. Would they feel that they were satisfied with things that are going on? And the outpatients were typically, because the outpatients require more attention, they always do. There's more staff attention required in the office. There's more direct physician attention required. And so because of that, they typically will say that staff explanation and medicines, they're more satisfied as an outpatient. Written health information, they typically are more satisfied in because it's directly specific to the physician instead of a group information packet, typically for numerous surgeons. Inpatients will typically have more lower responses compared to the outpatients on how prepared they felt when they were discharged home. And overall satisfaction, they're typically higher. So these are the people who've gone through it. Now, this is obviously skewed because the patients who were inpatients in this study were obviously older, heavier, higher trials from comorbidity evidence. They were sicker, older patients. So they typically are not going to be quite as satisfied anyway. This just goes to show you can make people safe and make them satisfied with these procedures. Now, on the flip side of that, not everybody's ready for this, and that's one of the things that you have to be ready for, and that's something you have to be prepared for. This was a survey sent out to Medicare patients, and 70% of them didn't think that they'd be able to undergo a total knee arthroplasty as an outpatient. So that kind of is counterproductive to what we saw before. We were expecting half of people going by outpatient by 2026. And so this is that perception that we have to A, overcome, and B, that understanding that not everybody's ready for this, and you can't put everybody into the same peg. So you have to have someone who's motivated. So that goes into, that's great that there's a need for it, it's safe, we can do these, but how do you accomplish this? How is it done safely? And this is probably one of the most important parts, and this is where all the time comes into these. So outpatient total joints, it's a very labor-intensive process on the surgeon and staff side. The patients, you don't have the added benefit of when they go to the hospital of having floor nurses staying with them overnight and talking to them multiple times. You don't have the hospital physical therapists working with them multiple times. You don't have the social workers working with them when they're in the hospital. You really put a lot of the responsibility for all of that goes on the surgeon and the staff. And so that's why it's so important to have a well-trained staff in order to be able to do this. And that's where the primary care docs on the other side, if they're involved and they want to be involved with this, becomes very, very helpful because they can help to ensure and reassure the patient this is safe, this is effective, this is part of the new norm that's going forward. So some of the big things that we have to work on, patient selection and optimization are key. You choose the wrong patients, if you don't optimize the patients, that's where you run into trouble and you run into complications. Preoperative education is paramount, and I'll talk to you about how I do that as well. Pain management, if you don't have good pain management, people aren't going home. Some of the studies that you'll see in the literature are showing 20% failure rates on outpatient. I have not seen that in my practice, but I think it's because the anesthesiologists are incredible. So the anesthesiologists now, especially in this area, have become phenomenal, and the pain management, the blocks, and keeping the narcotic loads down has really helped tremendously mobilize these patients, keep their pain under control, and lower the risk of some of these issues that we run into with narcotics. There's some intraoperative and perioperative factors, which we'll kind of briefly touch on. And then postoperative access, this is crucial. They have to have access to you, they have to have 24/7 access to your staff, and they have to be able to feel comfortable that you are going to be responsive in order to do this. So patient selection and optimization, kind of take it into two different sides. So there's patient optimization and there's patient selection. So patient optimization is something that I hold dear to my heart. It's something I'm a very big fan of, and it's something I've done ever since fellowship, and I've carried it on through into my practice, and we'll talk about one of the studies and some of the things we worked on here a little bit with that. And then the second thing is going to be patient selection. So preemptive wristoxidization, this is one of the big focuses for me personally. I use this for all my joints, but it's imperative with these outpatient total joints. If you don't optimize and minimize some of these factors prior to surgery, you're going to run into complications. You're going to run into bad complications, especially in the outpatient setting with these patients. So BMI is a big strict one of mine. Super obese patients have an 8.4 times higher risk of developing complications than the average weight patient. This is the #1 modifiable risk factor that we have, and I think it's almost criminal for us to be operating on these people without asking them to lose some weight. Some of the big complications that we run into is acute renal failure, respiratory failure, infection, blood clots, and the biggest thing is wound complications. We run into massive problems with wound complications between the fat necrosis and other issues. There's a significant higher chance of being transferred to the ICU. So one of the things that we do in my office is we offer them nutritional counseling. We give them multiple recommendations for nutritional, surgical, and everything else counseling. And we ask them to lose weight. We follow them too. We make these patients come back for every 6 to 8 weeks for weight checks to see where they're at, and we keep an eye on them. We don't just tell them to come back when they lose the weight, because then they never lose the weight. We follow these patients, and I think that's important to be part of their care. Now, patients don't have to be a perfect BMI, but if we get patients to lose weight and we see them in the right trend, then we discuss whether it's time to start looking and taking on the risks together, and that's something we do. Smoking is an absolute no. Don't operate on smokers. Patients who we think are lying to them, we'll nicotine test them to make sure. And again, we offer them counseling. We offer them numerous things in order to help them. But this is a completely modifiable risk factor that will significantly increase their risk of complications. Smokers are significantly more likely to have surgical site infections, obviously pneumonia, postoperative strokes, and their one-year mortality is significantly higher after total joints than the standard non-smoker. So this is a completely modifiable risk factor, and there's no reason not to have a counseling session with these patients. And it's not, you can't even consider these patients for outpatient total joints. Diabetes is another one. There's multiple numbers on the hemoglobin A1C and fasting glucose that you can use as cutoffs. Most people use between hemoglobin A1C of between 7 and 8 for control before total joint arthroplasty. I think this is imperative in the total joint field. If you have an uncontrolled diabetic and you send them home, we always see these bumps in their blood sugars post-operatively. We see these in all these diabetic patients, and we'll see it for about 24 to 48 hours. One option is just not to include these patients in your outpatient protocol, which is quite reasonable if you want to go that route. For us, we just make sure that any diabetic has to be completely controlled, and we are extremely strict on the hemoglobin A1Cs and fasting glucoses on these patients in order to operate on them, because post-op hypoglycemia is not only going to be dangerous, but it's also a predictor of surgical site infection, wound complications, and readmission. So it's something that you have to manage as well on the outpatient side very, very closely, and our family care docs obviously helping us on the outpatient side. A tool that I use to help modify these patients, it's called an RRAT tool, or Readmission Risk Assessment Tool. It was out at NYU. And basically it looks at multiple factors from colonization of MRSA, obesity, nutritional cardiovascular disease, previous DVTs, physical deconditioning, and then obviously diabetes is included in that too, and people get a score based on their risk factors. Now, the importance of this is for modifiable risk factors, because what we see here, we have numerous risk factors here, and what we see on the screen is different risks have different odds ratios for readmission and complications in each patients. And we've done the studies here as well, and we've seen the same thing. So diabetics who are uncontrolled are going to have a significant 3 times higher risk of readmission than the standard patient. And the summation of these scores, if they have multiple risk factors, obviously will lead to higher odds ratios for readmission and complications. So these are ways to modify these patients prior to surgery in order to move them into a safer outpatient setting. This is some of our data here from Morristown, which we're getting ready to publish. And what we found on the bottom there, and on the most important part, is that if you have a score of greater than 4, you have twice the chance of a readmission and complication within 30 days than those less than 4. And if you get these patients with a scoring of over 6, then the complication risk goes up 17 times. So these are the people that we need to modify, and we keep these out of the outpatient population. There's too high of a risk with them, and we have to exclude them from the outpatient population, and we have to do everything we can to modify those risk factors so that way they're safer for not only their total joint, but their outpatient total joint. This is some of our study here, showing 30-day readmission rates, and again, the higher that RRAT score, the higher the risk score the higher the 30-day readmission rate. And what we see, if they have multiple risk comorbidities that aren't controlled, their readmission risk is almost a third, 1 out of 3. So obviously keeping them out of an outpatient population, they're going to run into complications. And obesity is our number one. So again, when I was saying before, that's our number one modifiable factor. There, that talks about that right there. And we can talk about moral hazards, at some point, whether or not we should be doing these patients or not. But I argue that it's our moral obligation in order to work on these modifiable risk factors prior to surgery and get these patients the help that they need. Otherwise, we're doing them a disservice. So patient selection. This is integral. If we don't select the right patients and we don't have the right help on board, this is always going to be doomed to failure. So when you see some of these, in the studies, some of the 20 and 30% failure rates where these patients have to stay overnight, it's because they're choosing the wrong patients or they're not optimizing the patients. It's almost, most of the time it's that. You want to pick your motivated patients. You want to pick your younger patients. And this doesn't have to be every single one. I probably do somewhere between 150 and 200 outpatient total joints a year. So there's a significant population that wants this and a significant population that wants to move forward with this. But you got to find people who are motivated. That's number one. Younger is okay. Healthy is key. Healthy, motivated patients. You want minimal comorbidities. You can't have people who have uncontrolled CAD, CHF, and COPD. Those are the people who are going to run into your cardiopulmonary complications. I won't do people with uncontrolled sleep apnea either. My concern is from the narcotics that these people are going to obstruct overnight, and I want them all watched. So if I got someone who has bad sleep apnea, there's no way I'm doing them as an outpatient. They're coming, they're staying overnight. Now they can fall into the rapid recovery protocol and go home the next day, as long as they did well overnight and we didn't have any obstruction overnight, and I'm fine with that. But those are the people with the big necks, those are the people you really got to be concerned about having a lot of narcotics, going home and sleeping overnight. Those are the people that can get you in big trouble. Uncontrolled diabetes, like I said before, that's a recipe for disaster. The first 24 to 48 hours after surgery, their blood sugars are going to go up. And if they don't have that controlled preoperatively, you're going to end up running into trouble down the road. High anxiety patients. Anybody who's scared to go as an outpatient surgery should not be going as an outpatient surgery. If they have too much anxiety about it, if they're concerned about it, it's setting you up for failure, it's setting you up for complications, it's setting you up for the midnight readmission, which you don't want. High BMI, that kind of goes along with the sleep apnea. Patients with these high BMIs can get themselves in trouble mostly with respiratory issues, and so that's where you want to stay. Those on significant preoperative narcotics. The reason why you're going to run into trouble there is they don't have good pain control, and as the blocks slowly start to wear off, they can't manage their pain effectively. So these are the people who you're going to run into with the 2, 3 o'clock in the morning phone call that say, I'm in uncontrolled pain, I have to go to the ER. And so that's why you got to be careful about people who are on significant doses of preoperative narcotics. A coach, they got to have a drill sergeant. They got to have somebody who's with them. Whether it's a wife, a husband, a son, a daughter, even a neighbor, whoever it is going to be staying with them, they have to have a coach available, and the coach is imperative. So the coach we make there for all of the preoperative assessments too. The coach is someone who's going to help them through with the course for the first week or so and be their person to lean on. The coach has got to be the person who's going to reassure them when they need reassurance, who's going to help them when they have to get up to go to the bathroom, when they have to do these things, and to make sure that they're safe. Nobody is allowed to do outpatient total joints without a coach. It can be done, but it can't be safely done. And I wouldn't recommend it. And the coach has to be involved in all the decision making, because the patient will oftentimes just breeze past most of the things that you're saying because they're overwhelmed with information. The coach is your backup. The coach is someone to help you with everything. And then uncomplicated surgery. You don't want to be doing 2, 3, 4 hour surgeries and trying to get them going home as an outpatient. It's too much fluids. It's too much swelling. Those people will end up running into huge issues with swelling and pain control, and it's just setting you up for failure. So part of our education system involves a preoperative physical therapy assessment too. This is something I do that's a little different on top of it, but I think this is one of the biggest things I've done to see patients not only feeling more comfortable post-operatively, but also helps to weed out some of the patients that you think are going to be okay and then just aren't. I really feel that these studies that you see where you have 20 to 25% failure rate in the outpatient setting where they're not going home and they're getting admitted into the hospital are because that we're not screening or evaluating these patients well enough. And this is one of the things that we've done in order to do this. We sat down with some of the physical therapists and we said, all right, what do we see as risk factors for patients who are not going to make it from a stability and from a balance standpoint? And that's where we came up with some of this testing. And what we do is we send all of our patients for this pre-op physical eval with a physical therapist, and we go over an entire program about physical therapy that's going to be required. We test them for their balance, their strength, and their stability, and to make sure that they can do things not only on one leg, on two legs. We check their balance, and we check how they're going to respond to this. This is, if they don't score high enough on our setting, then we take them out of the outpatient realm, and we move them more into an inpatient realm because we have fear that they're going to have balance and fall issues post-operatively, and we don't want that. The other thing that we do is we do walker, cane, and crutch training prior to surgery. So all the patients will be coming in to the physical therapist who are outpatient. They bring their walker, and if they want either cane or crutches, they bring those as well. The physical therapist not only shows them how to use them, but they also set the correct heights for them. They make sure that they're safe with them, and they go over all of that so they're not doing it post-operatively. They already know how to use it. It's already set for them. They're ready to go. The other thing is it provides assurance to the patient. They've been there. They've done this before. There's a whole program for it. We have a whole booklet for it. This also gives us a chance to optimize strength and balance preoperatively. They get preoperative PT with this, along with exercise sheets and things to work on at home while they're waiting for their joint replacement in order to maximize their strength and their balance prior to the surgery. So this is kind of part of our handout too. Again, this is things we go over with them. We show them how to walk with a walker. They get this sheet with everything on it, with diagrams, pictures, and everything else, going over these things. We show them how to use the cane. We show them how to use the cane appropriately. They take them out to the car. They show how they're supposed to get in and out of the car for both hips and knees. They sit them down. They show them how they're supposed to sit, stand, and get up and down with the walker. We also take them over to stairs. We run them and show them how to use stairs post-operatively, so that way when they're doing it after the joint replacement, it's not new to them. They've already seen this before, and they're much more comfortable with it. So everything is about reassurance, making sure people are comfortable. If you can give people information, and if you can show them how it's done, then they become a lot more relaxed and a lot more receptive to the idea. These are other things that are gone over too at home with the physical therapist as well. And again, these are people that I've sat down with and I worked one-on-one with in order to do this. We have them go through a Q&A list on different things with floors. You know, can they walk through the furniture? Can they walk around the furniture? Do they have pets? How many stairs do you have? Are there broken steps? You know, even little simple things. Can you access the light switch, or is your light switch upstairs? Because you don't want to be trying to walk up and down the stairs in the dark if you've only got one light switch at the top. They go through the kitchen and the bathrooms. Are they going to have to make a step to get into a bathtub? Do they have a walk-in shower? What's available in the bedroom? What are they going to be doing when they have to get up in the middle of the night? And so those are all the things and the questions that we go over ahead of time to make sure they're safe and prepared before they go home. It's always better and always more cost-effective and time-efficient to take care of these things preoperatively and answer all these questions preoperatively and make sure this is all taken care of ahead of time, rather than to try to catch up later on when they get home and then the patient is overwhelmed because they feel like that they can't accomplish what they're trying to do. If you get to the point where the patient's overwhelmed, you have lost, and the patient is going to end up getting readmitted, and that's where you're going to run into your problems and complications. Preoperative education. Now this is a big integral part for us. This is something else that we do with both the staff and the PA. We also run this with anesthesia as well, and it's important to do all these things. Now, we've already talked about the PT side. We've also trained all of our staff and everybody else on how we're going to do this. So my PA knows exactly what we're going to do. We have multiple printouts that we give to the patient and the coach on exactly the medications, exactly the schedule, exactly what's supposed to be done. We give it to them in the pre-op appointment. We then post-operatively give it to them and the coach as well, and then it's also discharged from the facility as well, wherever they're being discharged. So they're getting at least 3 copies of this every single time. We also spend at least 30 to 45 minutes with each patient for our preoperative, what we call our H&P, in order to go over the procedure, go over the medications, go over all the instructions. These take significantly more time than the inpatient total joints, because all of the instruction has to be done prior to the surgical episode. Trying to catch it up later gets you into trouble. Coordination of care has to be run through the surgeon at all times. Everything has to go through the surgeon. When people are making different decisions, and when somebody is making a different decision on your patient, it leads to poor outcomes and confusion. Coaches are required at all of these preoperative visits. Again, we always like a second set of ears. And it's very important that all the fears regarding this have to be quelled, and expectations have to be made clear. If you tell a patient you're going to go home, you're going to feel good. You're going to feel good the next day, and 2 days later the blocks are going to wear off, but that's why you have the pain medicine. That's why we started you on the things ahead of time. People understand that when those things wear off and when they start to have the pain, because that's part of the expectation. If people go home without pain because of all the blocks and numbing medicine, and a day and a half, 2 days later, everything wears off and they didn't expect it, you run into problems. So pain management, this is a big, huge key. How to keep patients with good pain control and minimize narcotics. Narcotics lead to side effects. Too many narcotics and the patients don't go home. We do this through multimodals, peripheral nerve blocks, intraarticular injections, and short-acting spinals. So multimodal pain management. It's different based on the procedure for me, but everybody has their own way of doing it. But it's been shown in numerous studies. It reduces opioid consumption, it decreases your complication rates, it improves your patient satisfaction, and it promotes early recovery. So this is a combination of intraarticular injections, neuraxial anesthesia, preemptive anesthesia. I don't do PCAs or patient-controlled, local infiltration, and then opioids are our breakthrough. So my preoperative mix that I use for total knees is Celebrex 400, OxyContin, Lyrica, and Tylenol. Now, there's some studies recently calling into question Lyrica. Over the past 10 years, all the studies have been positive on it, but some of the new ones coming out over the past year have been a little bit more down on it, and that's something I'm looking at as whether or not I'm going to get rid of. I don't use the Lyrica for my total hips. I only use it for the total knees preoperatively. And the OxyContin I don't use for the total hips either because they don't have much pain. But I do use it for the total knees. The one downside to the OxyContin is you'll see these patients will have a lot of postoperative nausea. Not all of them, but some will have post-op nausea in that first 8 to 12 hours afterwards, and it's something you have to manage. And patients who are very sensitive will preempt them with Zofran and sometimes even scopolamine patches. But we try to keep the scopolamine patches away from guys because we see too much post-op urinary retention in them with the scopolamine. Blocks. So this has been huge in making outpatient joints a reality and making it safe and effective. So there's many different types of blocks you can use. Our anesthesiology colleagues have become very, very adept and very good at these. In Morristown, the guys are phenomenal at it, and in the outpatient setting, they're great as well. So there's Adductor Canal blocks. The newer ones, the IPAC block. We have intraarticular injections and short-acting spinals, which I like. I love short-acting spinals, but you have to be efficient to use them. So the Adductor Canal block, it's a great block. We used to do femoral nerve blocks. And the problem with femoral nerve blocks is you can't have someone go home outpatient with a femoral nerve block. There's too much quad weakness. There's too much risk of fall. There's high fall risk when you do these patients with a femoral nerve block. So we try to avoid these pretty much at all costs. The Adductor Canal block, though, it's great because it's a sensory-only block to the anterior aspect of the knee. It's done under ultrasound by the anesthesiologist. Typically takes them only a few minutes because they've done so many now. It takes only the sensory portions of the saphenous and obturator nerves, and as they're leaving the adductor canal, and that's done under ultrasound. And you can see I got a picture there the adductor canal in between the vastus medialis, the sartorius, and the adductor longus. There's multiple different mixtures that people use. Some people use Exparel, which is that liposomal bupivacaine that can last up to 72 hours. Some people use Marcaine. A lot of people use ropivacaine. And this is something that you got to keep an eye on just for Marcaine toxicity, especially if you're using blocks and other things. These have been shown to provide great anesthesia to the anterior knee. And most importantly, they've been shown to reduce falls, improve quadriceps strength, and improve recovery compared to femoral nerve blocks. And there's non-inferiority studies on them for pain control as well compared to femoral nerve blocks. So you're getting the same anesthesia basically as a femoral nerve block, but you're getting it without the motor weakness. So for me, for total knees, these are an absolute no-brainer. IPAC blocks, the interface between the popliteal artery and posterior capsule. These are relatively new. So the adductor canal blocks are going to hit the anterior knee. These are going to hit the posterior capsule and the posterior knee, because not everybody does intraarticular injections and capsular injections, which I think are imperative to keeping people not so stiff afterwards and getting motion. These obviously provide anesthesia to the posterior knee. These we're seeing a lot done with Exparel, because you get that nice 72-hour relief from these in that posterior knee without having to inject the posterior capsule intraoperatively. They've been shown in multiple studies to lower opioid consumption, increase early ambulation, and also increase knee early range of motion. So once you get the adductor canal block and the IPAC block, you're basically covering the entirety of the knee. And so these patients are quite comfortable for the first 48 to 72 hours post-operatively. So this is our window to get people up and get people moving safely with minimal narcotics. And this is how we're doing it. The hips, I'm not blocking. I know I will do intraarticular injections in them and intracapsular injections in them, but I'm not blocking them. There are numerous blocks for the hip, but I found that it's really, especially with me doing an anterior hip, I'm not seeing significant pain. I'm not seeing significant narcotic usage, and so I'm not using blocks on the hip because there's too much risk of femoral, iatrogenic femoral nerve or nerve injury, or just some leaking over from the anesthetic and causing a femoral nerve palsy, which can cause these patients to have significant quad weakness, and then they can't go home the same day. Spinal anesthesia, another great invention or great application to outpatient total joints. Some people are still doing these with general anesthesia for their outpatients, so that way they don't have that lag in motor function, which is okay. But with spinal anesthesia, we're seeing decreased operative room times, decreased PACU times, because we're not seeing some of the respiratory depression that we were seeing with some of the general anesthesia patients. There's a decreased risk of coronary artery CVA with these people. There's a decreased risk of pulmonary complications, obviously, since we're not intubating them and we just kind of keep them under a twilight sedation. There's a decreased risk of overall complications, and because of the hypotension that we see with these patients with spinal anesthesia, there's also a decreased risk of blood transfusion, which is ideal in the outpatient setting where you have to keep blood loss to a minimum. Something I've been using and we're working on studying right now, because there's not a lot on the literature with it, is chlorpropane spinals. It's a very short-acting, you're only going to get about an hour and a half out of it, but it's a very short-acting spinal anesthetic, so you get decreased recovery time with these, which is great. These patients are coming out of the OR and they're already starting to move their feet, move their toes. Obviously, it's leading to faster early ambulation, much less urinary retention with these. But the problem and the downside is because it's coming off so quick, there's obviously a little bit higher need for breakthrough pain medications in recovery. So that is the downside to it. Where compared to your mepivacaines and bupivacaines, where it's a little longer spinal, you're seeing a little more urinary retention, and it's obviously taking them long to get home. But the upside for those is you're getting a little bit less pain medication. So everybody's got their ways of doing it. This is something I like because it's just such a fast-acting spinal. So what are some of the intraoperative and perioperative factors that we can work on? So obviously minimally invasive techniques. We've gotten significantly better at those. There are intraarticular injections, hemostasis, and then postoperatively worrying about urinary retention. That's one of the big things we've run into with gentlemen in the post-op. So total hips, one of the things I love, I do a lot of these. I pretty much primarily do this now. It's an anterior total hip. It's a muscle-sparing approach. You don't have to split the gluteal muscles, and you don't have to remove the short external rotators, which is nice. And because of the approach, you don't have to have hip precautions. It's been shown to have lower rates of dislocation with these, but it definitely has a steep learning curve. much faster recovery. These people are up and moving. We utilize the plane between the femoral nerve and the superior gluteal nerve, and we split between the muscles so we don't have to cut them. Obviously, lower dislocation rates. The advantage is no hip precautions. So you don't have to teach people hip precautions. It's a very unnatural position to have to dislocate an anterior hip. And so that's why we see the lower dislocation rates. The one downside to them, it's a harder approach to do. So it's a very steep learning curve with these. So early on, people have high fracture rates and the surgeons who do them. Also, you'll see a little higher superficial infection rates on these patients in the early phases because people are tensioning the skin and beating up the skin, but that gets better as time goes on. And then intraarticular injections. This is another huge thing in trying to get people home the same day. If you're going to get them home the same day, you got to keep the narcotics down. If you can't keep the pain levels good and the narcotics down, people will never make it. So a Ranawat cocktail is from HSS is something that I use. It's a marcaine, epinephrine, toradol, solumedrol, morphine mix. It's great in providing that first 8 to 10 hours of anesthesia for people as they're first getting up while some of the other things are going. It's definitely been proven to show shorter recovery room times, hospital stays, lower narcotic usage, and decreased complications. So something that's easy, quick, and it's absolutely no-brainer. And then Exparel, I touched on before, it's a liposomal bupivacaine. You can get up to 72 hours of delayed relief. It's surgeon dependent when you place it though, because wherever you place it, it kind of stays. It doesn't infiltrate like some of the other solutions do because of the liposomes. So you have to place this in numerous areas throughout the knee, and it's very tedious to do it sometimes. You got to be cautious with bupivacaine toxicity, especially if you're using bupivacaine spinal and bupivacaine blocks. You can talk to your anesthesiologist about maybe using bupivacaine or something else with its blocks so you don't run into that. And the studies are obviously mixed in terms of efficacy out there. Hemostasis, tranexamic acid. Love tranexamic acid. This is, to me, the most influential thing in outpatient joint that we've had. TXA, most of us know the mechanism of action. By not having big swollen knees and not having significant transfusion rates, we've enabled ourselves to be able to get patients home safely and immediately. It's been shown to have decreased pain, decreased blood loss, decreased transfusion rates, no increase in risk of DVT, and it's safe in even high-risk patients. There's numerous studies out there showing that. This has been phenomenal for both decreasing our transfusion rates to almost none. Some of the new studies coming out are saying, do we even need to type and screen these patients? Because between the spinal anesthesia and the tranexamic acid, we're almost not transfusing these patients. So there's been a call as to whether or not we even need to type and screen these patients anymore for total joints. And it's safe. The side effect profile on this has been phenomenal, even with increased use in these and increased use in high-risk patients. So between this and blocks, this has been the key to transitioning people to outpatients and doing it safely and making sure patients are happy. And then urinary retention. This is just kind of something that I ran into as I was doing this. I would say in my first probably 150, 200, we had about 3 patients who we had to send home with a Foley catheter that we did completely outpatient. It was all guys who just couldn't urinate. And that was the biggest thing that we were running into. And so I sat down with some of the urologist colleagues and said, what can we do? And we looked at some of the studies. And then we found intraoperative fluid was our number one risk factor in this. And fluids over 750 cc's intraoperatively gave us an increased risk of 2.3 times for post-op urinary retention. So now we limit our fluids to under a liter during the whole post-operative process. Because that was one of the things that we saw is, the patient can't urinate. Let's give them some more fluids. Let's give them another 500 cc's. And we were overloading these patients. And then they couldn't urinate. And then now we ran into the big 700 cc distended bladder, and that's where we ended up putting the Foleys in for those couple patients. And we were doing absolutely the opposite of what we should have been doing. So we sat down, looked at the literature, discussed with some people, and that was one of the biggest things we found is you don't overload these patients. And if you don't overload them, and if you keep them up, and if you keep them walking, then they do well. We also, within an hour and a half of surgery, we try to get these patients up and walking, and we're working with physical therapy. Physical therapy comes out, and that also helps out with some of the post-op urinary retention, and that's something we've initiated immediately. So these patients, our 7:30 case at 8:30 is out of the OR. By 10 o'clock, we want them up and walking, and that's our goal, and that's also helped with that as well. Limiting length of surgery, there's a direct correlation with time. As you start to get over an hour with these total joints, your risk of post-op urinary retention starts to go up. So you really need to be efficient with these patients so you don't run into these things. No spinal opioids, that's a big no-no. You obviously keep morphine out of the spinal. We started initiating Flomax twice a day, 2 days prior, and we do it now for 4 days post-operatively as well. And we felt that's helped tremendously with our post-op urinary retention. Ever since we've initiated these protocols, we've probably done another 250 or so to 300 joints since then, outpatient, and we've only had one case where we had to send them home with a Foley. So it's been significantly. And then straight catheterization, you don't multiple straight cath these gentlemen. If you have to straight cath them, you do it once. Otherwise, it's a Foley. If you straight cath them multiple times, it just makes it worse, and their chances of avoiding become lower and lower. So that's kind of what we've run into with our outpatient experience. We talked about how to make it, why we're doing it, how to minimize some of the complications, and how we get people through the process to make it safe, efficient, and a good experience for everybody. We found it to be very safe and effective. Patients are happy. Patients like going home, and people are very happy with it. When you educate these people, they're actually happier. Their patient satisfaction scores improve, and you're seeing that time and time again. People are grateful for that. This significantly lowers for the healthcare costs, and especially some of these high deductible plans that we're seeing now. That's a big key to some of these patients. The most important thing is you got to train the patient and you got to train the staff. These patients require significantly more hand-holding, and they require significantly more time and effort on the surgeon's side, and that's something that you have to be involved in. Otherwise, these patients are doomed to fail. And soon, I really truly do believe this, and we're seeing it happen in front of us now. Outpatient total joint arthroplasty is becoming the future. Whether it's complete outpatient to the rapid recovery 24-hour stay and home the next day, this is going to be the future of total joint replacement. So we have to be ready for it. We have to prepare ourselves, our patients, and the community for it, so that way we can do this safely, effectively, and make this a success for everybody. So with that being said, I'd like to go ahead and open this up for questions for anything that anybody has.
As a reminder, text chat is located on the right-hand side of your screen. To submit a question, type your question in the small text box at the bottom, and when finished, click the send button. Please note that due to time constraints, our panel may not respond to all questions submitted.
So we have one from Bridget here. It says, explain rapid recovery protocol. So rapid recovery protocol is about early mobilization. Early mobilization involves getting people up as soon as possible. So for me, I like to try to get this done within 2 hours on all my outpatient joints. So we set our goal at an hour and a half because I use a short-acting spinal. For my inpatient joints, patients that are in the hospital setting, it's a longer-acting spinal, so our goal is 4 hours because it takes a little bit longer for some of the spinal anesthesia to wear off. So rapid recovery protocols are about early mobilization and early ambulation, and that's what we want to do. Everything is focused no longer on CPMs and laying in bed and elevating the leg, but on motion of the knee and walking and ambulation. So that's what that entails. Early PT, early mobilization, early range of motion. We decrease complications such as DVT with that. We can now I use a baby aspirin as my DVT prophylaxis, and we don't see the numbers of DVTs because of that. And I feel patients just do better. The next one is by Robert. Says, please comment on the TKA incision issues on home patients. So what we do, and I do this on both my hips and knees, that's a good question, because the old way of doing it was staples, wrap them up, and numerous dressing changes. I do all subcuticular stitches, so it's all underneath the skin. Excuse me. Then what I do is I do a skin glue or a Dermabond mesh layer on top of that, and then a waterproof dressing on top of that. So the combination of those, we don't really see much drainage at all because we have 2 closure methods on top of a waterproof dressing, so we just don't see the drainage. And then by putting on the waterproof dressing, the patients can go home and they can shower the next day without taking off the dressing. The dressing stays on for 10 days, and they don't have any care for it. There's no wound care or anything else. So if you're sending people home, because that's a great question, you can't ask people to change dressings and monitor things. You're setting yourself up again for failure. So instead, what we did was we sutured underneath the skin, all subcuticular, we glue on top, and then a waterproof dressing. The next one's by Barbara. It says, do most insurances and Medicare cover the PreOp PT and PreOp education? The pre-op PT is covered. The pre-op education is not. So that is something that we do separate. It's not covered, and that's all done by myself and my staff in order to make the experience better for the patients. So that's why I was saying this requires significantly more effort on the staff and surgeon part, because you have to prepare these patients, and it's your responsibility to make sure they're safe and they understand everything. So that's not covered. Now, the pre-op PT is covered, but it still comes out of the number of PT sessions that they get annually based on their insurance, which Medicare is one of them. So no, the pre-op education is not covered, but it's imperative. You can't do it without it. Whether it's covered or not, it's imperative to everything. Are there any other questions? All right. Well, if there's no more questions, I'd like to thank all of you for your attention. If you need anything from me, please feel free to call or email me. I'm happy to answer any questions. Is there a way for me to put my email up there? Does anybody know?
You could just go ahead and share it.
Okay.
If you would like to just spell it out loud.
Sure. JMDUNDON14@gmail.com. So please feel free anytime, email me or call me if you have any questions. Happy to talk about it. This is absolutely something that I love and I'm very passionate about, and I'm happy to be a part of it.
On behalf of Morristown Medical Center Orthopedic Surgery, I would like to thank you for your participation in today's event. A post-event survey will appear requesting your feedback. Please take a moment to complete this brief CME evaluation summary form to receive credit for attending the webinar and providing feedback of the webinar. This concludes today's program. Thank you and have a great day.